Hello, everybody. Thank you so much for joining us today. So just before we start the webinar, we have a few announcements. So next week, the ventilator round is on Tuesday, the 27th of September at 9:30 Riyadh time on the use of P0.1 in the assessment of respiratory drive. So if you don't know what that is, like me, then you can come next week to find out. And we really hope you appreciate the high-level scientific programs on ICU Reach and that you might consider supporting it through subscription as either silver or gold supporters. And in so doing, you will gain access to a range of additional educational materials as well. So tonight's talk then, our webinar is by Dr. Ibrahim Alsanouri on drug allergy in ICU, as you can see there. So if you have any questions throughout, if you keep those until the end, then you'll have an opportunity to ask Dr. Alsanouri. So Dr. Alsanouri is a pulmonary critical care, neurocritical care and immunology allergy specialist. And he is the Associate Programme Director at McLaren Medical Centre and an Assistant Professor at Michigan State University. So I'm really looking forward to hearing what he has to share with us today. And I hope everyone else is as well. So I will hand over to you now, Dr. Alsanouri.
Thank you, Jenny. Thank you, everybody. I hope you hear me well. I just hear an echo. I hear an echo.
No, it sounds good, Ibrahim.
Sounds good? Okay. All right. Good evening, everybody. Good afternoon for the North American participant. Good evening for our friend in Riyadh in the Middle East. This topic is basically just to clarify a few issues about allergies that can be encountered in the intensive care unit. This is about me. Graduated from Damascus Medical School, Syria. Did my residency in chief medical residency in Case Western. My fellowship in Wayne State. I'm board certified in allergy, immunology, pulmonary, and critical care. And you can read through this later. And this is the most recent picture of me on the left side, I hope. I have nothing to disclose other than I'm a good friend of the founder of this group. So right into it. I hope by the end of this lecture, drug allergy is something very broad, particularly in the intensive care unit, but I want to shed some light on the most life-threatening, most encountered drug reaction that we see in the ICU. ICU, is a environment that is really high risk for developing drug reaction, and I'll go through that. Why is that in a minute? What I need you to know, what I need you to understand the subclassification and the classification of drug allergy in the ICU, because this is really has a significant implication on the treatment, identifying the drug that is culprit. As you know, discontinuing or cessation of that culprit is a cornerstone in treatment and management of drug allergy. So the sooner you know about it and the sooner you stop that medication, the better in the management and better outcome, obviously. Some of those allergies carries mortality around 30% in the ICU. I would like, to spend half of the lecture about, classification of drug allergy. But don't be afraid, this is something is going to be about, things that you already know. I'm just gonna put things in perspective. And the second half of the lecture will be talking about some issues with the actual drug allergy management of some of the medication that you will see in the ICU. Before I start that, I wanna, if you read the literature, you're gonna find a different interchangeable terminology about the drug reaction. If you want to go to the WHO, the drug adverse reaction is the broader terminology that defines drug allergy as a response to unintended, is an unintended response to a drug or it is metabolite in your system. Underneath that drug adverse reaction is what we want to talk about. It's a drug hypersensitivity reaction, or what we say drug allergic reaction, which is if you want to be precise, what we're going to talk today is about the immune reaction of your immune system. We're going to describe the immune system reaction toward a drug. That's what we say drug hypersensitivity reaction, which is an immunological mediated response to a pharmaceutical or a formulation agent in a patient who is sensitized to that drug with the previous exposure or without previous exposure to that medication. The drug hypersensitivity reaction, as you see, can be IgE mediated, and this is where everybody call it allergic reaction, or could be just an immune reaction, doesn't involve IgE. That's why I'd like to just keep calling it drug hypersensitivity reaction. But if you see me saying drug allergy or drug reaction, what I mean actually is the immune response, the drug hypersensitivity reaction to the medication. This is what I just said. Drug hypersensitivity drug adverse reaction can be divided into side effects, something I'm going to define in a minute, but this is not what we're going to talk about today. Can be defined as a drug allergy, which is IgE mediated, something we will be talking about, or drug hypersensitivity or immune reaction. All of this you're going to see in the literature, sometimes unfortunately used interchangeably. Just make sure that you know the difference. When we talk about drug hypersensitivity reaction, we talk about a distinct mechanism. I'm sorry about that. Distinct mechanism that mounts an immune response that cause a myriad of clinical scenarios and clinical diseases. The idea behind drug hypersensitivity reaction is a binding, it's a covalent binding between the drug or one of its metabolites, depends how big that particle is, and your immune system in a way that is going to mount a reaction. Side effects, on the other hand, is a normal, it's an unintended defect occurring at the normal dose, and this is usually related to the pharmacological properties of the medication. So medication beta blockers can cause bradycardia, calcium channel blockers can cause bradycardia, hypotension from ACE inhibitor, acute hyperkalemia from that. All of that is considered side effects. Obviously, has nothing to do with drug adverse with a drug hypersensitivity reaction or a drug allergies. Same thing when we talk about the drug toxicity. It is simply a form of a drug adverse reaction that happens with an overdose. Again, this is different than what we be talking about today. Why we care about it because it is something that is you can be encountered around anywhere between 10 to 15% in the hospital, adults or children included. Some of these studies mention that this can happen in 30% if you go to the hospital and record adverse reaction to the medication, drug related allergy. This is something can happen up to 15%. Some of those can come to the ICU easily and carries higher mortality. So it is something that you really need to clarify about understanding. Most commonly is antibiotics. That's what we see all the time. This costs a lot of finance and expenses in the hospitals, more than the cost that you have for cardiovascular or you're dedicated for cardiovascular care or diabetic care. It can cause, as I said, mortality, 1 out of 5 injuries or death per year to a patient who is hospitalized for a drug reaction. The reaction can be as simple as drug fever or a fixed drug eruption or vancomycin-related Redman syndrome versus a severe systemic life-threatening disease, such as what we're going to call a SCAR, systemic or severe cutaneous reaction, including the TEN and Stevens-Johnson reactions. What are the risk factors for drug reaction? Risk factors are, can be drug-related and can be host-related. If you go to the left side, the drug-related reaction is the higher the dose that you use, the more risk or the more risk you might have to develop a reaction. Using IV is simply more than oral. Large molecular weight agent, IV heparin included, contaminant use or any other medication also also is a risk factor to develop the reaction, and repetitive courses of the same medication. All of those factors in the drug-related column here, you can tell this is our ICU environment. We give a high dose of medication in an IV form and in a frequent intervals. We tend to use a lot of medication at the same time. Host-related risk factor is female gender. It carries higher risk to develop allergies to medication. The too young and too old people carries higher risk. Diseases that require repeated courses of medication, such as cystic fibrosis, antibiotics, bronchiectasis patient also carries the risk. And sometimes, not sometimes, some medication has been clearly linked to specific HLA type, and we'll go through that in a minute. Please note that atopy that does not expose you to it does not make you higher risk to develop a reaction. So if I'm having asthma and I'm having allergic rhinosinusitis, seasonal allergy, I'm not at risk to develop a drug allergy except for two medications, penicillin anaphylaxis. So if I'm atopic, I'm asthmatic, I have a risk to develop anaphylaxis toward penicillin. Same thing for latex and contrast media to do CT scan. Other than that, atopy, including asthma, allergic rhinitis, eczema, contact dermatitis, food allergies, is not a risk factor to develop drug reaction. Please, when I say drug reaction, means drug hypersensitivity reaction. So this is the outline of the lecture today. I thought I put this in perspective. We be talking about mechanism of reaction. All of this was put in so you can put in mind a framework when you see a patient with a drug reaction to medication, when you see a patient who you suspect a drug reaction causing a specific disease. So we will be talking about different type A and type B reaction, immune pathology, involvement behind a specific reaction, the clinical features that you might encounter, because some of the clinical feature can be specific to a certain drug, and the minute you see it, this is what this drug is causing. And sometimes the drug can cause a organ-specific problem, such as pulmonary toxicity caused by amiodarone, fibrosis by bleomycin, things like that. So later on, I'll be talking about certain diseases that you can encounter in the ICU. Those will consume half of the lecture. The second half will be talking about specific drug allergy, including desensitization and graded challenge. So we'll talk about this. Again, this is another framework that I created. When I see drug allergy, usually in my mind is this and something else. I will show you what this something else is. But basically, when I see a drug allergy, I want to know the timing of the reaction, whether this has happened right after a specific medication, whether this is delayed. Why is that? Because clinical phenotype also relate to the timing. Usually urticaria anaphylaxis happens quickly right after the medication is given, within 30 minutes, whereas other severe cutaneous reaction happen later on. And what the reason behind this is the immune pathology behind it. Usually an antibodies related reaction, IgE mediated versus type 2 reaction with IgG and complement happens roughly early after you give the drug, versus type 4 reaction, T cell cellular immune mediated reaction usually happens as a delayed reaction. Again, mechanism of reaction, hapten and prohapten theory, and this usually involve a drug reaction that happens immediate or early on versus the PI theory that I'm going to talk about, and this is becoming very hot in the literature. This usually a mechanism behind a delayed drug reaction. After that, what I need to know in my mind when I see drug reaction, I need to read the insert package of each medication and see what people has reported in the literature specific, as far as a specific reaction to specific medication. So pharmacological reaction, as we said here, type A versus type B. We're going to talk about Coombs classification of drug reaction because this is kind of important, and then we'll talk about the pathoimmune mechanism. Type A and this is WHO classification. Type A reaction usually is a predictable one. It's common. It's been reported. It's usually related to dose. This is a thing that I'm not going to spend my time on. But this is, you have to know it. You have to differentiate that from type B, where the drug hypersensitivity reaction will be included. So type A is something you see dose-dependent toxicity from a drug that is known to cause toxicity, side effect from some medication, just like sedation from histamine, secondary side effects such as diarrhea from antibiotics, or drug-to-drug interactions such as theophylline and things that interfere with the CYP system in the liver. Type B reaction, this is where our allergy reaction lies on. This is something unpredictable, has nothing to do with the dose, but I said earlier, higher dose is higher risk. This include within it intolerance, which is not allergy reaction. This is not type A. This is just, for example, tinnitus from aspirin. It could be just an idiosyncratic reaction, such as hemolysis from patient who has a G6PD deficiency, and include in it drug allergy or drug hypersensitivity reactions, such as anaphylaxis and things that we're going to talk about, and include in it, let's put it right now, pseudo-allergic anaphylaxis, which is a direct stimulation, a direct actually degranulation of your mast cells or your basophils early on in the reaction that cause a anaphylaxis and asthma-like reaction. We call it pseudo-anaphylaxis. So our diffuse our DHR is a type B reaction. So that's when I see a patient with drug allergy reaction, I have to differentiate between those two. Number two, between type A and type B. Number two, I really need to know the timing of that reaction. I have to dig in and see what medication and sequence of events that happen, and that usually make me think about IgE versus non-IgE mediated. Usually antibodies mediated reaction happen very early on versus T-cell immune reaction happen later on. This is just to give you a classification about the timing. We will be talking about the disease called AGIP, usually happen within a week. Usually macular papular exanthum happen within day 7 of the administration of the drug. The more severe ones, the more severe reaction happen later on after you give the medication. Stevens-Johnson, TEN, DRESS syndrome. Serum sickness happens somewhere here in the 7 days or in a week of giving the medication. I need to bring your attention. Some of the medication happens 24 or even months after giving the reaction. Something that patient might forget that he took over the counter, or something that he forgot that he took for UTI because it happened so long ago. We again will keep talking about the mechanisms of reaction. Here I would like to show you, the Coombs classification of drug reaction as you know it. This is not intended for you to to be worried about it. It's just simple type 1 reaction. Usually when you have a pre-existent IgE antibodies that is going to bind to your drug or one of these metabolites and can cause a degranulation of your mast cells or basophil and can grow and cause significant reaction. Usually asthma, acute allergic rhinitis, anaphylaxis is the mechanism is this. Type 2 reaction usually happens when you have an antibodies that be taken up by antigen and cause cytotoxic effect, and this is what we see in hemolytic anemia and some medication. Type 3, when you have an immunocomplex that happen in the plasma, antibodies and your drug, or one of it is metabolite, as an hapten or prohapten, it will deposit itself in some of the organs. Things like hydralazine causing lupus-like syndrome can be type 3 reaction. Type 4 reaction is a cell-mediated, T-cell mediated. This is where you see the rash, the Steven Johnson, the TEN, and so forth. This is, we can I want to show you this slide just to show you the different diseases lined up with different mechanisms. Type 1, type 2 with the hemolytic, type 3 with an autoimmune glomerulonephritis, and type 4, to be honest with you, most of your challenge would be in type 4, where it is a delayed reaction. Patient took the medication a while ago, and now he presents with the clinical syndromes that sometimes can be life-threatening. The reason I put this again is just to show you the different antigen that is, responsible for each and every one of those type reaction. Usually soluble antigen you need to develop type 1 or type 2 or type 3 versus antigen presenting itself to the T cells is what you need in type 4. Nothing, you need to worry about. Again, examples of each type. Type 1 is allergic rhinitis, asthma. Type 2 is a hemolytic anemia. Type 3 is a serum sickness. And type 4 is the macular papillary exanthema, the blister reaction, the Steven Johnson, the AGIB, the DRESS syndrome. Let me take you to the second concept of the mechanisms of the drug that you really need to know. We talk about two different hypotheses or mechanisms to develop reaction: hapten or prohapten hypothesis and the pharmacological interaction, the PI hypothesis. I'll have a clinical implication of this in a minute, so just bear with me. The drug itself, here we start with the I don't know, I don't see my arrow. What happened to my arrow? Anyway, so if you go to the left side, to the very left side, you see something. You see drug here. Here we go. See drug, hapten. The drug itself can be attached to your MHC molecule on the antigen presenting cells, and this complex will present itself, or the T cells will see that and will create a reaction and will create a clinical syndrome based on whatever you are destined to have. This could be from the drug, or one of it is metabolite. Now, the second mechanism is when the drug itself actually goes to the T cell receptor and change that T cell receptors. Now, all of a sudden, T cells, the other T cells will see this particular T cells as a abnormal, foreign, if you want to say, and it will start an immune reaction, and you end up with a clinical syndrome that we will talk about in a minute. Sometimes the drug go to your HLA molecule and change that in a way that's altering yourself, and all of a sudden this particular cell, the antigen presenting cells, become carrying something, becomes a foreign cell, just like like a graft rejection, and that will be seen by immune system, and that will mount a reaction. I think I put three of them here. Probably this is looking better and better explaining. We have something called hapten, hypohapten mechanism to develop a reaction, and this is usually consists of the medication, or one of it is metabolite, going right into HLA, being captured with a certain epitope here and presented. This is antigen presenting cells. The T cell will see that unusual peptide or unusual foreign part or foreign particle on the HLA, and there will be a reaction between the T cells and antigen-presenting cells, and then you encounter a reaction. The other binding theory is when this is called the PI model. This is the drug bind to the peptide on the HLA molecule. It's not picked up as a foreign. It just become it's the same HLA molecule you have, but it will be somewhat attached to it in a not in a different way that we see here. The third mechanism is your drug is changing your HLA altogether. Now this is a HLA type for a patient, HLA B27, B50, it become altered. And the T cells now will see this as a foreign cells and will start a reaction to destroy this, and clinical reaction will happen based on this theory. So those are three things. Usually altered peptide theory is usually happen when you have a severe cutaneous reaction, delayed reaction, cellular reaction. Hapten or prohapten theory happens when you have an IgE mediated reaction or antibodies, and the PI something in between, the pharmaceutical interaction model. We said that. It is just very important to know this, so I put another slide. Did I lose you guys? Okay. Okay. So this is another slide just to show you how that drug, penicillin here, going into HLA, not penicillin, I'm sorry, this is the abicavir, going into HLA B5701, causing a change in that HLA molecule. And then now all of a sudden, instead of having the T cell receptors and HLA MHC molecule interaction, benign interaction, self interaction, now become non-self. You alter the HLA and you get a reaction. This is the basic behind several diseases, or not several diseases, several HLA type linked to a several different drug reaction, particularly anti-epilepsy medication, abicavir, anti-HIV medication, some antibiotic, the list go on and on. So why particular patient has a particular reaction or develop particular reaction to a particular medication could be because that medication has caused alteration in this particular HLA if the patient has it, and that's can cause a problem. Ethnic association, you can see here from the third column that each medication, like say carbamazepine with the HLA type in a patient in a Han Chinese people, we see this population in Wisconsin, and many of these we see them. We see a lot of patients with this ethnicity, and if they have this allele, they receive this medication, they tend to develop a drug reaction, particularly Steven Johnson. Now this list, because of that, people started to make commercially available screening kit to screen people before they start certain medication. If you qualify for that, if you are known to be, to have this ethnicity, and you need this particular medication, people screen for your HLA, and this is something can happen in the office. And if you are allele positive to this particular type, probably carbamazepine should not be given because it carries higher risk for a drug reaction in this particular patient. The list goes on and on. Abicavir has a genetic screening kit as well, and I'm assuming, I'm expecting this is going to be more and more. Here are the other table just to show you how the list look like, and the different screening tests on the right side here to show you, which medication we can screen for before starting a particular medication on a particular ethnicity group that carries a higher HLA allele type reaction with a medication. So this is something, again, when you see a patient, put in your mind those three mechanisms: the hapten, the PIs, the altered self mechanism, HLA type, and try to subclass the drug reaction. Same thing as we talked about those two. I put this in perspective. So timing, clinical phenotyping, immune pathology, and antibodies versus not, mechanism of reaction. I think we don't need to talk about this. Let me see. Oh, here we go. So when I see a patient, right away it comes in my mind, I have to rule out type A drug reaction, making sure this is something I don't have to deal with. This is a type A reaction, not allergic reaction. When I'm confident this is a type B reaction, three things come in my mind. Is it allergy, immune? Is it related to one of those antibodies that pre-exist, whether IgE related, whether IgG related, or whether this is a T cell reaction, whether this is a PI theory where the drug binds to HLA type and cause alteration in self, and or whether this is just simply a pseudo reaction. Pseudo reaction is you take a medication, there will be no immune response. It will be direct degranulation of your basophils and mast cells. So I put those in three things in my mind when I see that patient, and I try to differentiate. Basically, if I have an allergic immune reaction, I'm talking about anaphylaxis, macular papular exanthem, hemolytic anemia. If I'm talking about PI reaction, I'm talking about most of the severe cutaneous reaction. If I'm talking about pseudo allergy, I'm talking about something that caused, just like aspirin, non-steroidal radio contrast media for in the imaging department that cause a direct degranulation of mast cells. And so when I have a patient, I really have to put them in one of those categories. The allergy immune, the PI, and the PI stands for pharmacological interaction, something that is changing my HLA. And I told you about certain medication has a certain affinity to certain HLA in a certain ethnic group. Perfect. Now we move from this to clinical features. I put here clinical features. Obviously, you probably know this. I don't have to tell you. I linked those. Just some examples. This is by no means exhaustive list. Just to tell you, anaphylaxis can happen from any medication, DRESS syndrome, particularly from sulfa medication, anti-seizure medication, lupus from hydralazine, proconamide, ionizide, and the list is too long. Clinical features also, when you see a patient with a drug reaction, there are different type of reaction, including drug fever, skin eruption, blistering, fixed drug reaction. I'm not going to go through this list details, but this is again something that you'll see in the ICU. I'll talk about the drug fever in a minute, but when you see maculopapular rash, this is a clinical feature you put in mind. You go back to your patient, you see the timing, you want to identify one of those three mechanisms I told you about, and hopefully you'll be able to treat this patient and find out what medication caused the illness. Just because it is very common, drug fever, I made one slide for it. It usually happens between 7 and 10 days. Release of cytokines that can cause fever, and usually stop after you stop the medication within 48 hours. Just the point here is this is something happened after a week of using the medication. So you can't use meropenem yesterday and have fever today and say this is a drug fever most of the time. Also, there is some exception. Organ specific, you can flip the side of this. Instead of talking about the disease caused by what, you can get systemic diseases, hematological problem, hepatic problem, pulmonary problem, and the medication that has been reported to cause those impairment in those organs. Like, for example, nitrofurantoin bleomycin is well known to cause pulmonary fibrosis. So if the patient was on this, he comes with this pneumonitis, particularly nowadays we use a lot of monoclonal antibodies. Pneumonitis is something, immune therapy, genetic therapy. Pneumonitis is something we see every once in a while. It's not uncommon. Something you put in mind. Some of the medication, has a specific clinical reaction reported in the literature. So also it's very important to look up when you see a patient who has a specific medication, go back, look up that medication, see what people are saying about it. Rituximab is something can cause cytokine. Not only rituximab, all the immune modulators that we're using cause a cytokine release syndrome. Patient comes with the ARDS and septic-like picture, hypotension, and even renal failure. This has been well reported in the literature. Nowadays, we're using a lot of immune modulators medication. Be aware of the things that has been reported in the literature when you evaluate your patient for drug allergy. Let's talk about certain diseases, certain we call it SCAR, or severe cutaneous allergic reaction, that you might see in the ICU. The first one we don't see that much, but I think it might have gone unrecognized, is something called serum sickness reaction. It's simply a antibodies that it is a type 3 reaction where there is an immune complexes because of the existence of IgG antibodies that interact with the particles of the drug and can deposit itself in different organs, in the skin, in the kidney. It causes a lymphadenopathy, fever, rash, arthralgia. Usually, this is something that happens in the first, maybe second week of using the medication. Patient looks sick. You might consider him as septic, but the patient is not that sick. He's coming to the office sometimes. You see him as outpatient. Probably you see it in the ICU, but it is rare. This is something doesn't bring usually patient to the ICU unless there is a significant, let's say, acute kidney injury, stuff like that. Usually the prognosis is very good. It doesn't cause a significant systemic reaction. Some of the immunoglobulin that you're infusing to the patient, any of the asthma biologics, Xolair included. I didn't hear anything about other biologics causing this problem. You're giving, immunoglobulin antibiotic stings, from insects. Insect bite can cause this. Tick bite can cause this. So it is important to go back to the history and examine the patient. And usually prognosis is benign. I didn't want to make questions about interaction questions, but I thought to present the second disease, it will be the best to just give you a case scenario. This is not intended to ask about, to have you answer this. It's just intended to give you an example of what's going on. This is an 18-year-old patient who took Bactrim for 6 weeks for acne, comes in with fever, neck pain, sore throat. You examine him. There is a lymphadenopathy in the neck area. He was started on azithromycin for that fever. He started to develop rash later on. His doctor thought he has a sore throat, so he gave him azithromycin. But remember, he took 6 weeks ago, he took Bactrim. I want to give a credit to the physician who went back to his history and figured this out. It's a month and a half ago when he took that Bactrim. He took only the azithromycin at the time when he developed the fever. Later on, after you saw him, he started to develop rash. He started to have a facial edema. You thought about angioedema, and you sent him to the ICU. You give him some epinephrine. You give him some steroid. His rash is macular-papular, very thin, very benign looking rash. It's not angry. It's not causing any sloughing. Patient has lymphadenopathy, as I mentioned. You did CBC. You thought about sepsis. You saw increase in liver function test. Something that you say, oh yeah, let's see what happens. Eosinophils were very high. Total bilirubin is slightly high. This is millimeter, I think, per deciliter. 55. This is less than 1 by American standard, or less than 2, I think. Lab, again, you have a higher liver function test. You have a eosinophil count in a patient who has fever, rash, lymphadenopathy. Bilirubin has increased. LLT, AST has increased day number 2 after you put him in the hospital. So what's your diagnosis? Again, this is not for you to answer, but it's just simply to make a point. This is something called the DRESS syndrome, which is a systemic reaction that happens days or even weeks after you give a specific medication. people can, categorize, the criteria in different ways, but main important things I put on the right upper hand here: the fever, the rash. Rash could be sometimes, evolve into Stevens-Johnson, and facial edema, eosinophilia, and patient looks sick on this particular reaction. If you fail to find out about this and stop the medication, and the patient continues to take this medication, or maybe you, for some reason, you give the same medication, things can be much worse. So the hallmark of this is eosinophilia, fever, rash, lymphadenopathy, and later on some systemic involvement, including hepatitis, sometimes including nephritis as well. People don't know why the patient will have this, but it is certainly a PI theory. It is certainly an alteration in the HLA molecules, and some people actually link this to one of the herpes virus, human herpes virus disease. Some people link it to CMV, EBV virus. Something happened that altered your HLA type and make you prone to have this reaction. Again, 2 and 8 weeks ago, patient might have forgot what medication he used. Treatment usually supportive. If you want to give steroid on this particular disease, the steroid has to be probably 4 to 6 weeks. 2, 3 days, 4 days, 5 days of steroid is not gonna cut it. You need more days on the disease. I have seen this a lot in my practice. This is acute generalized eczematous pustulosis. You see pustules like this. It's just simply a subcorneal reaction that actually stuff out the epidermis, and you had like rash like this. I have seen it many times. I can't tell you how many times I've seen it. Maybe every year I see 1 or 2 cases of this. Luckily, this is also a PI theory. Happens maybe days, maybe 2 weeks after the culprit medication was used. Maybe patient stopped taking that medication already, or might be on it, but it happens earlier than DRESS syndrome. Maybe a week, 1 week, 2 weeks, something like that. Very benign course, sloughing. All of these pustules can happen. You can get some edema, but usually systemic involvement is unlikely on this disease. We see it a lot. I've seen a lot of our colleague starting making LP and this and that, but this is really typical. And you don't really need to biopsy this. I've talked to some of our dermatologist colleague who said you don't even to biopsy this. This is Asia. Let it go. Stop the medication. May or may not give steroid, but this usually benign disease. I give you the causes on here and the treatment. Again, steroid benign disease. Stevens-Johnson and TEN, they are the same disease. We call TEN when the sloughing of the skin is evolving more than 30% of your surface area of the patient, including mucosal. When it is less than 10%, we call it Stevens-Johnson. Severe disease, severe scar, we call it severe cutaneous reaction. Again, PI theory happens with the T cell immunity. Very severe disease, sloughing in the skin, including mucosal membrane, can cause GI bleed, systemic disorder, sepsis-like syndrome. Patient usually need to be in the burn unit, taken care of. Usually this start and then evolve to a much more severe disease, and sometimes can stop. I've seen two spectrum of this. I've seen somebody who has it and stopped, and then I've seen somebody else who developed more systemic problem and end up dying. Sloughing of the skin, we all know about the Nikolsky sign. This is what you see in those diseases. Again, TEN has been linked to a certain medication with an HLA allele type, specific allele type. The table I showed you, carbamazepine, carbamazepine, abivacir, I guess. 1 second. Anticonvulsant can be linked to this disorder. People are screening before they start certain medication in certain ethnicity group, so we don't develop this. We don't need to talk about that. Usually the treatment is supportive and steroid is contraindicated. Some people give higher dose IVIG, and not some people, most of the people will end up with IVIG very high dose. This is maybe 2 milligram per kilo. This is not the same dose you give for your patient with myasthenia gravis or Guillain-Barré. This is something much higher dose. Supportive care, burn unit, skin wound care, steroid is contraindicated. I hope that I put these things in perspective for you. Again, put in mind when you see a patient, you talk about timing, the clinical phenotype, timing, the clinical phenotype, the immune pathology, the mechanism of reaction, and a specific drug reaction to specific medication. This is what should go in your mind. Don't be afraid of this. As I said, there are IG-mediated reactions that usually involve, that happens quickly, immediate. As you develop hapten or prohapten, you interact with the pre-existing antibodies and you cause all the cytokine milieu that gives you clinical syndromes such as anaphylaxis, angioedema, and urticaria. Once you start to have a more reaction with the immune system, more alteration in your immune system, changing the HLA, changing the T cell receptor, PI theory, you start to see diseases with the MPE, maculopapular exanthum. You start to see more systemic disorder, breast included, and later on see Steven Johnson and TEN. Not later, it's just a spectrum. So when you have a disease that happens quickly, immediately, usually this is in pre-existed IgE antibodies or IgG antibodies. When you have symptoms, when you have a delayed reaction, you'll talk about PI theory, whether you change the T cell receptor theory or change HLA receptor, and this is where you have an HLA association, and this is your clinical syndrome that you see because of this mechanism. Always, I need you to remember that there is something called a pseudo-allergic or pseudo-anaphylactoid reaction, where you give a medication and you get a direct degranulation of your mast cells, and you end up with symptoms similar to the symptoms you have when you have IgE, pre-existed IgE, but this has just happened directly. Again, when I see a patient, I put those three things in my mind, and I try to navigate and to understand better what's going on. Now, if I have a time, I'm going to go over a few concept of skin testing and allergies. Let's skip the question. I want to just talk about penicillin allergy. It's so popular and so common in the ICU. When you see penicillin allergy, I want you to know that penicillin share the same beta-lactam ring with other antibiotics, as you see here. Penicillin itself, when you have allergy to penicillin, most of your allergy, most of the time, 98% of the time, you're allergic to that beta-lactam. Where if you're allergic to cephalosporin, there is some exception here. Probably the amoxicillin will be, you'll have some allergy to the R chain. Cephalosporin, most of the allergy of the cephalosporin comes toward R chain, not particularly the beta-lactam. Let's not talk about the skin test that we have only, that is well have been tested, validated, is penicillin skin test. Cephalosporin we do have, but it's not as good as the penicillin skin test. So I'm not going to go through this because we don't do it much in the ICU. Let's go to. I'm going to skip the skin testing. Let's skip this. All righty. Okay. So just to what we know so far in the literature, when you have a patient who mentioned that he has a penicillin allergy, 90% of those patients will tolerate penicillin if you give them penicillin. 80, that's because they either forget how severe the allergy is, or they simply don't allergic to something else, or there is a 80% of the people who has penicillin allergy loses their allergy toward penicillin as the time goes on. What I do usually, if I have a skin test available in my clinic, I do it. You have to know this is only screening If it is positive, great. If it is negative, that doesn't mean anything, because you can still have other components, particularly minor allergen from the penicillin, we call it, that the skin didn't include it. But if you have skin test that is negative in your test, you can follow that with giving the patient amoxicillin PO. This is something we don't do in the ICU, but the idea is we don't really have a particular antibiotics skin testing that that we can use. And if it is negative, we say patient is not allergic to a particular drug. So that's not practical. So what is the practical point? The practical point is, if I have no history, remember, if the patient has a severe history for penicillin allergy, he's going to remember this. So if he doesn't remember it, or if this happened too long ago and you need to give penicillin, go ahead and give it. Now, if the history is suggestive of non-anaphylactic reaction, so patient remember, that he has, some kind of urticaria, rash, hives, you could do the skin test, and if it is negative, you're probably safe to give the penicillin. And if it is positive, you give graded challenge penicillin dose. This is different than desensitization. It's simply giving the same dose of the medication, you half it, or you give a quarter of it, and you just follow the patient within 2 hours. And if the patient has no reaction, you really don't have, you can continue that. Again, skin test is not available. If the patient has an anaphylaxis to penicillin, and he knows that, he tells you, I was in the ER, they gave me epinephrine, I needed to be intubated and in shock. Those patients, you really want to avoid that penicillin and give them alternative, or simply do desensitization. This is just a drug degraded reaction, degraded the challenge that you can do. You give 1,000 to 1/10. 1,000 not realistic. 1/10 of the dose, and then you increase it incrementally within 30 to 60 minutes, interval. And this is different. This is a much higher dose than desensitization. Again, we give it only for a patient who has, a reaction, hives, not anaphylactic reaction, and you really want to give him the penicillin. Then you can do that degraded challenge. Okay. Desensitization, on the other hand, is different. This is when your patient is allergic to penicillin and you want to give him the penicillin. You just don't have alternative. Then you give him a very fraction of the dose, and then you follow a lot of protocols that are provided with different hospitals, different departments. I really need you to understand the difference between the drug challenge versus desensitization. If the patient if you think the patient will tolerate the reaction, will tolerate the medication from what you go through with history, probably you do a degraded challenge. If you think your patient will have anaphylaxis, you do the desensitization. This is the difference. Cephalosporin and penicillin allergy drug, cross reactivity. You should know that the cross reactivity report that we got in the past, the 10%, famous 10% cross reactivity reaction between penicillin and cephalosporin, is something very old. It is wrong data. It used, people who use this was using contaminated preparation. It is usually not that high. It's less than 1%. If you're allergic to penicillin, your chance to be allergic to cephalosporin non-anaphylaxis reaction is less than 1%. Why is that? Because cephalosporin reaction or allergy is usually happen toward the R chain versus the beta-lactam ring in the penicillin allergy. Patient with a history of non-severe reaction to penicillin rarely react to cephalosporin in less than 1%. So you're allergic to penicillin in the past, hives, it's okay to give ceftriaxone, no questions asked. However, some cephalosporin shares the same R chains. So if you have, and I put a different group here for you that share the same R chain. So if you're allergic to one of those cephalosporin, probably you want to avoid the medication that is listed here to share the same R chain, because they will have the same reaction. Remember, amoxicillin also share some of the R chain with those cephalosporin. This is very important when you choose your alternative. If you have a patient who has a cephalosporin reaction, you want to use alternative. You want to use something that doesn't share the same R chain with the medication that you give. So you want to avoid that. Skin test for cephalosporin, you don't have to do it. This is just to show you a framework If you can hear me for a minute, if you have a patient who has a penicillin allergy and it is severe, you probably don't want to give him cephalosporin. You want to give him cephalosporin, but do it as a degraded challenge. If you have a patient who has non-severe reaction to penicillin in the past and you need to give him cephalosporin, go ahead and give it. There is no problem. This is what all this table is all about. Carbapenem, again, the reaction is probably less than 1% between the penicillin allergic patient and carbapenem. The cross-reactivity doesn't happen except for when you're allergic to penicillin. All of us know, I think I put it here, maybe not. Aztreonam monobactam is something that doesn't react with other beta-lactam, is your drug of choice when you have a severe reaction to penicillin. However, make sure you don't give ceftazidime to those patients who have allergy to aztreonam. Other fact in the drug allergy, sulfa medication. This sulfa, when you are allergic to Bactrim, you don't share the same antigen the other sulfa-based medication has. So when you're allergic to Bactrim, you're not going to be allergic to Lasix. They have different amine position, and the cross-reactivity doesn't happen. So it is okay to give a patient who has a sulfa allergy Lasix or thiazide diuretics and so forth. Vancomycin-Redman syndrome simply is just a cytokine release, doesn't involve any antigen and antibodies reaction. It simply can be taken care of by slowing the infusion rate. Angiotensin, I just want to mention the cough and angioedema, one of the reactions that can happen with ACE inhibitors. ARBs can be given, can be tolerated very well with patient who's allergic to ACE inhibitor and vice versa. Adverse reaction to biologics, I talked about cytokine release syndrome. This is something you see in the oncology ward when the patient is given certain immunological medication and present to the ICU with fever, rash, bronchospasm. It's just a cytokine release, and this can be systemic and can cause pneumonitis. Usually the prognosis is good with IV steroid and stopping the medication. I want to mention about the contrast media. This is again a pseudo-allergic reaction or pseudo-anaphylactoid reaction. It is a direct mast cell activation. The thing I need you to remember, this reaction here has nothing to do with fish allergy. So if you're allergic to iodine or you're allergic to fish, that doesn't mean I cannot give you contrast. When you're allergic to fish or shellfish, this is you're allergic to some of the protein that the protein in the meat, versus when you're allergic to iodine or the contrast media, you're allergic to the contrast itself. So there is no cross-reactivity between fish allergy and contrast. Radiocontrast anaphylactoid reaction, before you send your patient to have a CT scan with contrast, certain, as I said, A to B is a risk factor, as we said early on, to develop this anaphylactoid reaction from contrast, female gender, cardiovascular, and therefore you can pre-medicate your patient before he goes into to have a contrast, and that usually doesn't prevent it completely, but can actually medicate the disease. Cross-reactivity between non-steroidal depends on the reaction. If you have a reaction that is involved anaphylaxis, you have an aseptic meningitis from ibuprofen, it's okay to give naproxen or Aleve. So if you have a severe reaction from a non-steroidal, one of the non-steroidal, it's okay to give the other one. They don't cross-react. If you have a less severe reaction, urticaria or sometimes angioedema, actually, you need to be careful and maybe change the non-steroidal to a totally different drug type, whatever you use it for, pain or fever. I'm going to skip those questions, but basically it's just to put a point: allergic patient to cephalosporin at high risk to react to which drug? It's B, cephalosporin, that actually has the R chain. That was more tricky question. I guess I put a dissimilar reaction. I put dissimilar. So I guess the answer here will be penicillin. But I don't want you to hang up on the fact of answering those questions. So I'm going to go through them quickly. We don't have to go through this. In summary, we talked about that the drug reaction is not always drug allergy. Doesn't mean drug reaction, although you see me change, this approach to drug allergy should include detailed history, type and timing of the reaction is very important. Subclassification of the drug allergic reaction based on the clinical scenario, timing, the immune pathology is very important. Be aware that the risk factor for each severe drug allergic reaction is very important. You have to confirm allergy to a medication. Unfortunately, the only test we have is penicillin skin testing, which it's not readily available. Graded challenge, if you have a patient that you know he will hopefully tolerate the reaction from screening history and going back and forth, you can do that. For a patient who does have a high risk to develop a high reaction, you can just do desensitization. I want to throw here something called a polydrug allergy syndrome. Some medication don't cross react with each other. However, when you have a patient who's allergic to a medication, he has high risk to develop a reaction to other medication, although they're not related. So patient who's allergic to Bactrim, he has a higher chance to react to penicillin more than the patient who doesn't even have any allergies in the past. So that doesn't mean sulfa medication cross-react with penicillin. Put that in mind is kind of important. Again, one of the summary I need to put this in your mind when you see a patient. This is a subclassification. When you see a patient, talk about timing, identify the clinical phenotype, try to identify the immune pathology and the mechanism of reaction, and try to read the literature or insert package of the specific medication. Again, those are the three things that goes in my mind when I see drug reaction. I have to rule out type A reaction. And once I think this is type B, I want to see if this is an IgE mediated, IgG mediated formation of like antigen and antibodies, versus this reaction related to PI theory, whether I am having a change in my T cell receptor or change in my HLA type. And the last thing I want to know whether this is a pseudo allergic reaction where I have a degranulation of the basophils and mast cells that cause me to have the disease. Again, it's exact same thing, but I love this. I probably asked Dr. Kerala to put this on the website with explanation, just to put this in mind, how different clinical scenarios, all the way from the left to the right, has a different immune pathology behind it. Again, three of them with a different diseases. The timing, obviously, this is an acute or subacute. This is a delayed reaction, and this is an acute reaction. This is a pseudo allergic reaction. I think with that, I'll end the talk. I think I made it on time. Probably we might not have time for questions, but I'm here. I'm available to answer any of your questions if you have one.
Thank you very much, Dr. Alsanouri. So yes, just as before, if anybody has questions, feel free to unmute yourself or put them in the chat box. So I can see Dr. Kerala has a few questions there for you. So firstly, he has asked why steroids are contraindicated in Stevens-Johnson syndrome.
It's been linked to, this disease usually is a sloughing of the skin, opening the skin, very high risk for infection. Doesn't really ameliorate the reaction itself. Once you have a change in the HLA molecule, based on the theories we talked about, steroid has nothing to do with it anymore. It's just a time when your immune system has to settle. That's number one. Number two, the high risk of infection with this patient who's having opening the skin, opening the sloughing mucosa, upper and lower GI. Really, steroid will delay the healing of this, will cause more infection. None of the allergists or dermatologists recommend to use a steroid in those patients. IVIG possible, but not IV steroid.
Okay, thank you. Do pseudo-allergic reactions occur with future repeated exposure to the same drug?
For sure,
Yeah.
absolutely, yeah, for sure. It is unknown. This is we call it pseudo because it just I mean sometimes it skip like a period of time of somebody's life, and it comes again. You can take the contrast and you have this problem now, and later on you take the same contrast and you don't have any problem. That it is really there is nothing you can capture about this mechanism. It's just simply the drug decided to cause a direct degranulation of your basophils and mast cells, and can cause all this cytokine release, bradykinin, histamine, heparin, all of that. It can happen anytime. You have risk factors, as I mentioned, the female gender, previous history of A to B, cardiovascular disease, things in that nature. People are trying to avoid this. They're using the non-ionic contrast, which carries less risk of developing this. If you're talking about the pseudo-allergic reaction, you're causing a contrast causing a pseudo-allergic reaction. So you can take some precautions. That's.
So the steroids, Ibrahim, when we pre-medicate patients with it, does it apply to all types of pseudo-allergy?
It does. Steroid for any pseudo-allergy, you can give steroid just prior, and I gave you a protocol. I went over it quickly. You can go back to my site and see that protocol that we use all the time for patient who has that, who is suspecting to have it. Now, this is a prevention. When the patient has it, you use it. Obviously, it's a steroid. It can suppresses the mast cells. It suppresses the basophils, stabilize the degranulation. You give antihistamine 1, antihistamine 2 as well. You can give cromolyn sodium just to stabilize the mast cells if this has happened. Most importantly, to prevent it with the steroid. And if it happens, you treat it with the steroid and everything else.
Okay, thank you. And then we have a question again from Dr. Krella. How do you categorize the skin rash associated with ampicillin in a patient who has mononucleosis?
Probably macular-papular exanthem. I'll just call it macular-papular exanthem. It could be anywhere between target lesion, could be a morbidly-form rash. It can cause all kind of all kind of forms with this. It's usually benign. It should not go.
What's the mechanism, Ibrahim?
Mechanism is again, this is possibly a PI theory. Any viruses, as I mentioned before, like a DRESS syndrome, not a DRESS, and even DRESS syndrome particularly. Any virus that goes inside, it will be picked up. That you will have infected with. It will alter your HLA type. It will alter your self. So MHC molecule will pick up the EB virus, and because of any reason, it will change the HLA type. And with that, you create a reaction. Now, all of a sudden, your antigen presenting cell is non-self, and it will be attacked by the immune reaction. And that can manifest itself on the skin or everywhere else.
And it looks like it's mainly related to the herpes virus groups, right?
Correct. And it's a PI theory. I think it's a PI theory. It's a PI mechanism. It's a PI immune pathology causing HLA type alteration.
Okay. If a patient has a severe pseudo-allergy to radiological contrast, can that be used again? And if so, how going forward?
Sure. It cannot be used, as we mentioned before. You can pre-medicate this patient. You take precautions. Sometimes, non-ionic contrast, and pre-medicate the patient with a steroid. I think I put. Let me go back and show you the. Here we go. The protocol. So you can use a non-ionic contrast if it's available, and then you use this protocol just prior to this. This is given prednisone 50 milligram hour 13 before the test, hour 7 before the test, 1 hour before the test. You give Benadryl 50 milligram 1 hour prior. You give a dose of albuterol, and you give, you know, one of the H2 antagonist, and you have you can have the contrast. Most of the time, this is takes care of it. I never seen somebody that I used this protocol and had a reaction afterward. But in the literature, they say it might not work, but you know, in experience, this works all the time. So 50 milligram, 4 doses, 3 doses, I'm sorry, 13 hours prior to the test, and then 7 hours prior to the test, and then 1 hour just prior to the test, and then you can do it. In addition, you do the Benadryl, the albuterol, and the H2 blocker, like a Pepsid or, you know, antihistamine, anti-H2 blocker. That's what you do. That's how you prevent this from happening.
Okay, yeah, so that links to our next question then, which is about steroids specifically. So for pre-medication with steroid, if a patient's going to contrast CT or coronary angiography, how long before, perhaps you did cover that there, how long before for steroid pre-medication?
I make sure, let's say I want to do it 8 o'clock in the morning tomorrow, 8 o'clock in the evening, the night before, I give the patient 50 milligram prednisone or whatever it is equivalent IV for. And
Ibrahim, what if it is urgent contrast CT, like for pulmonary embolism?
Yeah, it's, you know, it is tough question. I would give him IV solimedrol, Benadryl, albuterol, and I prepare you know, H1, H2 blockers, Benadryl, Pepsid, IV solimedrol. And, you know, I'll take precaution. I'll just send somebody with the patient, observe him in the ICU. If I need to do it stat, patient need to be observed in the ICU. Airway management, airway alert has to be alerted. And, you know, things can happen, obviously, but you take precaution.
Okay, so if anyone has any final questions, we'll do those now. And if not, then that's us for today. So I think that is all our questions in the chat box anyway. Thank you so much, Dr. Alsanouri, for your talk today.
Thank you very much, Jenny. Appreciate it. Thank you very much.
Thank you, Ibrahim. Thank you, everyone, for attending this fantastic presentation on drug allergy in the ICU.
Thank you very much, Thanks.